But we're going to go ahead and get started with our National Prevention Week webinar on prevention, kind of a prevention 101 and harm reduction, just kind of getting back to the basics. I will start with a little bit by telling you about Upstream. We are a nonprofit founded in 2015 with a mission to support systems level changes to promote public health. We specifically focus on behavioral health as a whole, which SAMHSA defines behavioral health as that mental, emotional well-being and or actions that affect wellness. And so for us at the moment, this means we address substance misuse, suicide, and mental health awareness. We are primarily funded by both governmental grants at the federal, state, and county level, but we also have some private and community foundation grants. And just like most nonprofits, we accept donations to fund those items that the grants won't cover. This webinar and this community education series is funded through the Division of Mental Health and Addiction from our Community Prevention Grant. So we're excited to offer these this fiscal year. At least we did them once a quarter. We will continue that next fiscal year, although possibly increasing with frequency. So our objectives for today is to start by just defining prevention and harm reduction, emphasize that guiding approach of prevention and the role that harm reduction can play or should play in a comprehensive approach, and ideally to identify areas we can collaboratively address substance misuse. And we've got a lot to cover. I think that what I think at least is the most important with this is looking at this approach to harm reduction incorporated into prevention. Harm reduction is not new. It's been around for a long time, but partnerships within that prevention field, I think, has been lagging in a lot of places. I also have a quote to put up here, and it is blurry. I didn't realize it until it was too late this morning, but I do want to take a pause to acknowledge that the language does matter. And so we've got this quote from Michael Botticelli, who is the former director of the Office of National Drug Control Policy. And he just reiterates this importance of using destigmatizing language. For many of us in the field who've been doing prevention in a while, we're used to this in some aspects, but I think some of us, or most of us, hopefully are able to say individuals who use drugs versus addicts, right? But there is this push that's happening to talk about substance misuse prevention versus substance abuse prevention. And so that's the phrasing I will use throughout this webinar. We're focusing on substance misuse prevention and harm reduction for substance misuse. But it is a harder one for those of us who have been in the field a while. I think it is harder to stop calling it abuse and instead call it misuse. So feel free to call me out if you notice that. I need all of the help I can get sometimes. I also want to give a disclaimer that part of the slide deck was developed by the Great Lakes Prevention Technology Transfer Center, or the PTTC, which is funded by the Substance Abuse and Mental Health Services Administration, or SAMHSA. So obviously the opinions expressed don't reflect the position of SAMHSA. They have an excellent training on prevention's role in harm reduction that you can see on their website, that they then pulled slides out and created as a turnkey presentation for participants to present in their communities. So we have a hybrid. So we've got some upstream content that you'll see and some content from the Great Lakes PTTC. I left the slide designs stand, so you should be able to very clearly see the differences. But if you have a question as to what was Upstream created or PTTC created, please just let me know. And while I can't see your wonderful faces, I am hoping that this is going to be a little bit interactive of a webinar, at least as is feasible as the Zoom structure that we have is. I do encourage you to use the chat box for any questions you have, especially if you'd like those answered as we go. So feel free to interrupt and put it in the chat. I will encourage you to make sure that you change the to everyone so that everyone can see it, not just me. And so drop those in there. We can use the Q&A pod, but that's a little bit harder for me to navigate to. So if you can just use the chat to interrupt me, I would greatly appreciate that. Sorry, my wheel got ahead of me. And with that, we'll get started. So hopefully this continuum of care, this model looks familiar to many of you. This is from the Institute of Medicine. It is the more updated version that has recovery on the far right. But we often use this model to think about the different ways that individuals interact with health, or in our case, and what we're talking about today, how they interact with substance misuse interventions, all the way, starting with promotion on the left, all the way through recovery on the right. So promotion, which is also along the bottom, these are strategies that are designed to create environments and conditions that support behavioral health and the ability for individuals to withstand challenges. So this is building resilience, building that supportive network, those protective factors. And as I mentioned, promotion strategies should also reinforce the entire continuum of health services, as you can see along the bottom. As we move along to the, half circle, that protractor, we get to prevention. And so the CDC defines prevention as activities to stop people from getting diseases or to stop a disease from getting worse. So this set of three wedges are further broken into either primary, secondary, or tertiary prevention, or as you have on the screen here, universal, selective, and indicated prevention. We also often consider universal prevention efforts those that are aimed at the entire population, whereas selective prevention is those that are focused on individuals that either have an elevated set of risk factors or a depressed set of protective factors. And then the difference between selective and indicated is that indicated is for those who have started to engage in the behavior that we're trying to prevent. So if we look at these three wedges and think about alcohol use, universal prevention, we might think of as something that we implement at the middle school age. So most of our middle school students are not engaging in substance use, aren't drinking alcohol. So we might call anything we implement at that middle school level universal prevention. As we get into some of that high school seniors, college freshmen, who are experiencing some big transitions in their life, we might start to think about some selective strategies with them because they have that elevated risk factor of transition, as well as just getting to that age range where it might become more popular or more common, even though most of our high school students and even most of our college students, for the most part, college freshmen, aren't engaging in alcohol use. But that indicated level, we might focus on that for our college students. So that first year experience, some of those, individuals at that collegiate level or at an institution of higher ed who have started to consume alcohol, but likely don't have an alcohol use disorder, right? So they have started to engage in the behavior, maybe binge drinking, that we're looking to prevent. As we continue along the continuum, we'll run into treatment. So these are services for people with diagnosed with a substance use or other behavioral health disorder. So this is where that disorder or the disease is actually happening. And so, unlike prevention, treatment is designed to identify individuals who are experiencing the problem theoretically as early as possible so that we can get them help and get them into treatment as early as possible. It should be, treatment, just like anything else along the continuum, should be evidence-based and using strong evidence for implementation and for approaches. And again, it's not necessarily looking at individuals who are engaging in the behavior, so that college freshman who has maybe been drinking, but those who have that problem or disorder. So, that super senior or young adult who maybe has started drinking in high school or early in college and is unable to get through the day without using alcohol and is experiencing signs of alcohol use disorder, that would be somebody that we would focus treatment effort with. And then as we move over, we've got this recovery section that used to be called maintenance. And so these are services that support individuals' compliance with that long-term treatment and aftercare. So part of it is recognizing that some things, getting to that point where an individual is engaging in mutual help and support programming, something like Alcohol Anonymous, again, staying on this alcohol theme, may be a part of treatment, but is also super important for most people in that recovery and maintenance spot. So this is, once someone has, quote unquote, graduated from treatment, how do we maintain that recovery or maintain them in that space where they need to be? And so for most of us in the prevention field, which I think is probably about half of us. When we think about prevention and the efforts we do, we've most likely followed those first two wedges on the far right, or sorry, on the far left. That universal prevention, that health promotion, especially if we think about substance misuse prevention for youth or substance use prevention for youth, thinking at that K-12 level, most of what we're doing is in that health promotion and universal prevention. But you'll notice that we are talking about harm reduction and prevention. So I'd like for you to put in the chat, where do you think harm reduction goes? Does it, go on the far left under promotion? Does it go somewhere in the prevention wedges? Is it, in treatment? Is it in recovery? Should we just change the whole thing red for harm reduction? Where do you think harm reduction goes? Okay, so we've got a prevention indicated section or vote. Anyone else want to chime in? Across the spectrum. Got some prevention. It might help you for me to say that there's not a spot on here that at least the big broad field has identified that, hey, we should wedge this piece in. But the goal of harm reduction is to reduce potential harms to individuals, families, and communities. Again, we're talking specifically today about substance misuse and substance use disorder. Even if that substance use behavior doesn't end. And so for the most part, a lot of entities and individuals will think of harm reduction policies as a type of prevention effort. So we've got a couple of the three of you who chatted, we had two prevention and one across the spectrum. And I think that all of that is correct. So we want to think about harm reduction, not just limited to kind of at that big, broad community level, but also at that individual level. So how do we reduce an individual's risk of infection, accidental injury, disease, the negative consequences of, an accidental overdose or, sexual violence that often travels with substance misuse? How do we do that? And oftentimes that falls into that prevention area. There is also a hot topic because a lot of practitioners, scholars, investigators, we don't all share the same viewpoint, right? So the biggest spot of contention, specifically with harm reduction, is thinking about how do we view addiction and substance use disorders, but also how appropriate is it to adopt harm reduction approaches to solve the problems that we see, and doing so as we think about prevention in a traditional manner. And so this adoption of a recovery orientation as we think about substance misuse and substance use disorder, specifically how our programs are designed and implemented, all of this are these kind of hot topics. And as Kimberly is putting out, is there any work being done to integrate it across the spectrum? It depends on who you ask, and it depends on the viewpoint and who the practitioner is. That is one of the things that Upstream is starting to tackle. More so is this incorporation of harm reduction into the efforts that we do, because we're trying to increase, public health, and we're trying to increase quality of life and perceived quality of life. And for some individuals, we can't do that without talking about harm reduction. It also, when you start to challenge the viewpoint of what is harm reduction and what does it look like, and as we expand prevention beyond, 0 to 18 or even 0 to 20, we start to think more in harm reduction terminology and viewpoints. So yes, Kimberly, there are pushes happening, but there is also a lot of pushback that is happening. And so we're not going to solve any of these challenges today. I don't have a magic wand, but if any of you do and can wave it, please feel free to do so. But my hope is that we can start this conversation specifically in Johnson County, but also I know we've got some individuals from across the state here, but thinking about how can we better collaborate and support harm reduction in our community, either within our prevention entities like we're doing with Upstream, or whatever, home or set of homes makes sense in your community. And we can't talk about prevention without talking about the strategic prevention framework. So for those of you who know this, I promise I'm going to keep this very brief, or at least as brief as I can. But it is that approach that we use in the prevention field to make sure that we're doing the best prevention that we can with likely limited funds that we have. So while I can literally spend days talking about each of these phases, and because we've got some from the prevention field, some from the general community, and some that I don't know your background, we're just going to do a high level flyby for this. So we're going to talk through each of the phases here. We're going to dig into each of the phases just a little bit, and then we'll get to how we can work together. So on this SPIF, the Strategic Prevention Framework, I call it a flower, but on this SPIF model, we start with assessment up at the top, which is our approach to understanding the nature of the problems and the related behaviors. We have to assess what are those underlying risk and protective factors that are contributing to those problems and related behaviors. And we also have to assess our capacity to even do something about it. You can think about this as our snapshot of what's going on in the community. So we know where we should focus our efforts and resources, but it also can give us that strong baseline of what's going on so that we'll know, in the future if we've actually been able to have an impact. As we move, I'm going to talk about it linear. It is not linear, but as we move to the right, we'll move into capacity, which is made up of resources and readiness. So resources can be time, people, power, knowledge, funding is a big one, right? So it's what resources do we have at our disposal, but then looking also at that readiness. So the willingness and motivation in our community and in our staff and in our organizations to actually address the problems that we have. We can think of our capacity both as those who, it's quote unquote our job. So organizational staff, prevention staff, as those professionals, but also the capacity of our community. Because we have to be able to get people to understand and see that prevention is everyone's job. It's everyone's business. Prevention is possible for any sector or any job to look at things a little bit different, and there are things that they can do in their daily job that will help us as we work towards our prevention efforts. And so we've got to build up both as appropriate. We've got to build up our staff that we have so that we're all staying on the cutting edge. But we also have to build our capacity in the community by making sure that we're engaging, diverse stakeholders, that we're strengthening our prevention team, and that we really are building our community buy-in and our community awareness to actually do the things that we need to do. As we continue on, we've got planning. So we need to build this plan, figure out what exactly we're going to address based off of our assessment and our capacity. Got to think about what are the best interventions or the best fit of interventions for our community. What can we actually do and what can we not do? For those of us in the prevention field, I think we often think about planning in terms of the grants. So most of us, a lot of us will have a single year grant. We've got an action plan or a work plan or a strategic plan that we have to do. If you're an LCC, a comprehensive community plan. So we need to think about those terms for our plan and what we do. The other half of that is that many of us might think of like a 5-year strategic plan and to get there. But my challenge to you that we're not going to get into here, but to think about is how can we make our prevention and our substance misuse plan a hybrid of those? So broader than and longer than just a single year grant plan, but maybe not, so nebulous and so vague as to a 5 or 10 year strategic plan. Thinking of broader than just this funding stream can pay for these things, but what is it our 1 to 2 year goal for our prevention efforts or for our community efforts to tackle substance misuse? How do we get there? What partners do we need? And then what actual activities do we need to get to where we want to be? Some of that may be grant funded that you can work into a grant plan, but some of that may need to be using our training and our backgrounds and our strengths as preventionists to then be able to utilize and pull in partners so that we can do the best prevention and the best efforts possible. We never talk about, I feel like, implementation as much because we spend so much time talking everywhere else. But if we've done a strong assessment and capacity building and built a strong plan, implementation is just implementing the best strategies we can, making sure that we're paying attention to fidelity. We're trying to adapt our programs as we need to, but ideally minimally, and making sure that we have implementation support so that we're not only picking strong strategies in our planning phase, but then we're actually implementing them so we would expect to get results. And we look for those results in our evaluation. So looking at the outcomes of implementation, looking at the fidelity and the process evaluation of how things were implemented, and then the impact and the outcome evaluation for the effects of those efforts. Looking at, where are we now, both from the programs or initiatives that we've implemented, but feeding back into assessment to what does our snapshot look like now. In the center, you'll notice I skipped around. We also have sustainability. It's labeled cultural competence from the SPIF, but I tend to talk about it more in cultural humility. This idea that if we aren't operating inclusively and with humility to the individuals with different lived experiences and letting them tell their story, we're not going to have the impact we need. And I think especially as we start to incorporate more harm reduction strategies and efforts into prevention, or maybe into our more traditional prevention, this becomes even more important. And so we'll talk about this in a couple of slides, but if it's super important to include throughout each of these phases, and to always have that lens of, are we being inclusive? Are we listening to the people we need to listen to? But then also making sure that we're working towards sustainability, because even if we get the impact, most of us don't have grant funds that are, in long-term or long enough term that we can keep things going forever and ever. So challenging ourselves not to think about sustainability as sustaining and keeping programs going, but getting to the outcomes that we want, and then moving those outcomes so that those outcomes and those impacts stay. So when we think about assessment, we want to ask ourselves what is going on, right? So what's the nature and extent of substance use problems and behaviors? What are those risk and protective factors that influence those problems and behaviors? And then what actual resources and readiness do we have to address them? We do know, prevention science tells us, that we can't always change substance use problems and related behaviors directly. We can't just educate our way out of the problem, and we can't just walk around, smacking cigarettes or vape pens or, red Solo cups out of people's hands to get a behavior change. So instead, we have to focus on those underlying risk and protective factors for those problems, and then work on building this comprehensive and balanced plan to address as many contributing facets as we can, or to at least identify the ones that are important so that we can bring in partners who can address maybe some other contributing facets in collaboration with us. So we can only solve a problem by understanding it. So we have to worry about gathering our data, and as much data as we can, and as strong of data as we can, while also not living in this assessment realm forever. So thinking about, again, what are those problems? How often are they occurring? Where are they occurring? Who is experiencing these problems more? So we think often about health disparities or health inequities. Again, what populations, should we be focusing some of our efforts on because they're experiencing these, but also making sure that we've got that population at the table so that they can actually help guide us and do more of that decision-making versus somebody, coming in on high and saying, oh, this is exactly what you need, right? We need that collaborative spirit. And as we collect this data, we've got to prioritize it, right? So I guarantee you that if you do a big, strong assessment, you're going to come up with more things to tackle than you actually have resources and readiness and funds and all of the bandwidth to tackle. So we've got to prioritize, right? And therefore, that's our first challenge. So in the universal and primary prevention field, as we're collecting data, we then often prioritize based on magnitude. So which problem is the largest, our time trend, what's getting worse year over year, that severity, is it resulting in mortality? Is it more costly to the community? And then places where we can, we look at it comparatively. How does it compare to neighboring communities, to the state? Looking at nationwide, how do we compare to other people, other entities? And again, most of us, or at least those that are on the call that I know your background, we focus on youth. And so when we think about this K through 12 youth, and we work through this prioritization categories, we inevitably are going to come up with alcohol, marijuana, and nicotine. Used to be cigarettes, probably more so vaping now, but we can just go with nicotine, cannabis, and alcohol. That's most likely going to pop up as our problem, and that's fine. And so for youth, we usually preach and work towards abstinence because at their ages, again, that 0 to 18, using any of these substances is damaging to their developing brain. It's also illegal, and I wouldn't change that. We should preach abstinence to our youth. But you can see how that then causes challenges as we start to take prevention across the lifespan, right? So when we get to adults where, alcohol use and vaping and cigarettes are legal, how do we then talk about prevention to adults where it's something that they can do? And oftentimes many can do in moderation and it doesn't impact their life negatively. So when we start to get to that point and start to take it across a lifespan, that's where we have to incorporate harm reduction. But I think most of us don't think of our approaches at the adult level as harm reduction. So we'll tackle into this in a little bit, but just as a heads up that as we start to do this prioritization, it's important to make sure that we're comparing similar data as we're putting it in there, but also recognizing that it matters on the age range. Something that might flag as a problem for 0 to 18 may not be as big of a problem for someone, 35 to 45, right? So if I've got 20% of my population of youth that is drinking alcohol on a regular basis, so on a monthly basis, that's probably something to worry about, that 20%. If I've got 20% of my 35-year-olds that are drinking alcohol, but they're drinking in moderation, once a month, I'm probably less concerned about that. And as we start to identify what those problem behaviors are, and again, at those age ranges and developmentally appropriate, we have to start digging into the why. So we said earlier that prevention focuses on these risk and protective factors because we can't change that behavior. And so this is where we really want to focus our efforts. So focusing on risk factors, which are those characteristics. So at that biological, so in my genes, the psychological, my family, my community or cultural level, that precedes and is associated with an increased likelihood or a higher likelihood of problem outcomes. So for risk factors, this could be that my community, if we're talking youth substance use, we might think that our community sees it as a rite of passage. And so there's low enforcement for youth to drink after prom. That is a risk factor, that community acceptance, that environmental acceptance, that low enforcement. All of those are risk factors that can be associated with an increased likelihood of those problems. Protective factor, on the other hand, is not exactly the opposite, but it's still those characteristics at that individual, family, or community level. But these are characteristics that buffer the problem. What is important is to note that these risk and protective factors aren't deterministic. Not like I look at someone and say, oh, you've got two risk factors, you're doomed forever, right? Or, they don't cancel out either. So I can't look at somebody and say, oh, you've got 2 risk factors, but it's okay, you've got 3 protective factors, you're fine, right? We all have risk factors. Some of us have more than others. And ideally, we all have protective factors. And we can always build up protection, build up that protection and that buffer against the negative impact of those risk factors, build up that resiliency, increase that community connection and that culture, because all of those can be protective factors. Because as hard as we try, we're never going to get rid of all of the risk. And so prevention isn't just trying to eliminate the negative behaviors and that risk factor. It's how do we support protective factors and strive, again, to get to that higher quality of life and that well-being. And as we move through and we've picked out some of our risk and protective factors, we've got to then think about our capacity. And so how ready is our community to actually accept that a problem needs to change, much less than to actually take action to change the problem. And I think, again, this is where we run into a challenge, especially as we start to think about harm reduction and prevention across the lifespan, because I think a lot of communities, at least in Indiana, and at least the ones I'm familiar with, where we've at least accepted that we don't want our youth drinking heavily or, using some of these substances. maybe not universal, because otherwise most of us wouldn't have work, but we at least have gotten to the point where we accept that this is something that needs to change, and we're building that action. I think it gets a little bit hard to then think about our community readiness as we start to think about opioid use, right? So we've got this complete uphill battle, thinking about addressing substance use or misuse as a moral failing, which it's not, right? It's still a disease. It is, changing the brain chemistry. Individuals who, are addicted or have a substance use disorder, they can't just stop, right? They need that extra support. They need that extra help, and they need that extra support as they get to the point where they're ready and able to get that help. So as we build this capacity, this is where we need to start to think about, what do we have? What are our strengths and shortfalls in our resources? Where are our gaps? What are those realistic matches between the problems and the ability to address them? And then do we have the things that we need to address them? And Kimberly has a question in there about how it might be problematic to focus prevention on substances. I would agree with that to some extent, but I think it's also one of those, chicken before the egg thing, right? Most of the funding that is out there, or when we try to get funding and support, whether it's grants or donations or, just any sort of money, it's a lot easier to say that I'm trying to prevent alcohol use in youth, or to prevent, overdoses, or, something like that, as opposed to say, oh, I'm trying to build up this protective factor and reduce this risk factor. So I think the way Upstream tries to approach it is looking at those risk and protective factors, but focusing a lot on those shared risk and protective factors, or to focus on those factors that have the biggest impact on the things that we're trying to address. So we do a lot with talking about social connection, and how, youth see adults in their life as one of the driving factors in their decision not to use or not to engage in substance use. But also social connection can help provide that outlet for adults, especially when it's positive, right? So having those protective factors there, we can address those. We know it's going to have impact on our mental health and our suicide rate, as well as on our overdose and, substance misuse problems. And so as we start to think about how do we tackle this, what are our resources and our readiness, this is where we really start to think about who's at our table and who should be at our table. And I think this is one area where a lot of us in prevention think we're really great, but we're just as guilty as others as, not intentionally, but excluding entities or other individuals with lived experience, or not getting them onto this, collaboration ladder, I guess what it's called, to the point where they need to be. And so when we think about community resources, we often think about those fiscal resources or those organizational resources in terms of money and infrastructure. But human resources is something that is super valuable, and takes a lot of cultivation and a lot of attention, and sometimes is easier to just ignore because we've got our heads down and we're fighting, against all of the things that we've got up against us. And so for human resources, we want to think about making sure we have the, quote unquote, right staff with experience or credentials, those consultants and volunteers who can help. But we really need to focus on, do we have the right people at the table who have the lived experience, who can help us get to the point we need to be. We talk about this a lot in prevention with coalition building. And I know that there are a lot of us out there who do the prevention work that are, do our best to build our coalition and to get the right people at the table. And it's not easy. I fully recognize that. It takes a lot of effort, takes a lot of conversations and a lot of engagement, especially now where everyone's, tapped out and burnt out. It takes a lot of willingness by those individuals that we're trying to get to join us, to have the interest and the desire, and that, something that's in it for them. But even pre-pandemic, when I used to work with communities across the state, most of those community coalitions did youth prevention work. They focused on that K through 12 youth, but with no youth representation, or at least no meaningful youth representation, or at least no youth representation that's at the same table where the money and the decisions are being made. And so they may have had really great efforts, but if you're not getting the buy-in and if you're not listening to the population you're trying to support, you're not going to hit and get the results that you need to, and you're not going to be as inclusive as you should. This is especially true as we start to think about harm reduction and moving into some of the, stereotypical harm reduction strategies and approaches, because we can't just be the individual to come in and say, oh, you use substances, you need to stop right now, right? We need to have those people at the table to figure out what do they need, how can we best get that to them, how can we use their knowledge and experience and their desires and needs to then actually try to provide them and leverage our strengths against each other. And again, I didn't mention, I think earlier, I don't have a slide for cultural humility, but this is super where it plays in. Oh, I'm taking so long for some of these, sorry. So as we start to work through it, we've got to pick our best fit for our strategies, making sure we're focusing on things that are important and have the biggest impact, but also things that can change, but then also things that are, effective, that they conceptually match our problems that we have, and then this practical fit is that they can actually happen in our community, that we can actually address them. They are something that we could tackle with the resources and the readiness that we have. Some of this will also come through as we, get ready for implementation and evaluation. If we build just a super simple logic model where it makes sense going, left to right, that we've got this problem and related behaviors that are impacted by these risk factors, and so we've chosen this strategy. But you could also think of it backwards. So if I implement this strategy, then these risk factors will change. And if these risk factors will change, then these problems will change. If I get all of the caveats, right? If I get significant dose and duration and, population and all of that. I'm going to spend the least amount of time on this slide, but this is one of my more big soapbox issues, and we don't really have time for that, especially because I'm long. So this is super simple of a logic model, and it's really important that we make sure that it goes back and forth, that we're not, putting up a sign that, says don't drink, or, drinking and driving is dangerous, or you could die, to address opioid use, right? It's got to make sense back and forth. And the more we can focus our limited resources and, again, bandwidth and, readiness on things that will actually have the impact, that's where we can, push forward and have. So as we kind of walk out of prevention, just some of these big guiding concepts is that prevention needs to be balanced. So as much as we can, we need to think about prevention and supporting individuals throughout the lifespan. Again, I think especially in Indiana, a lot of us have focused on that K through 12, but it really is something that we should focus across the lifespan, understanding that different ages have different challenges, but looking at it in a balanced approach as well as a comprehensive approach. So we are all not one thing. We all have intersections of identity, and how can we, address those health behaviors that maybe fit into different, funding categories in a comprehensive way. And again, I think as preventionists, we are uniquely positioned where we can build these broader approaches, and we can use our, for some of us at least, very well-trained or overtrained or overeducated practices in some of these areas to expand out our scope. And so that way we can actually start to build out plans and support other health behaviors as they relate back to us. Needs to be evidence informed. To me, that's a no-brainer. And it needs to be evaluated. We need to know whether or not it's going to work. And this is where I think it's also important, is to make sure that we're making it a shared responsibility. It has to be shared between the individual and the environment. If we want to see an individual's behavior change, it's partially that individual's role to change their behavior, but it's also partially the environment's role to make that behavior change possible. It means that we need all of those stakeholders within the environment to understand that it's their job to approach changing the environment as well. Again, this is one of those things you can't do a prevention training without the socio-ecological model. And this is just focusing on the fact that we have prevention strategies that work at each of these levels, at that individual. So getting that individual behavior to change, interpersonal, so making sure that My peers, my family around me are getting strategies for prevention as well. But then we have to look at, what's our community environment like, and then that big broader society. And what is great about this is that you can still tackle harm reduction at each of these levels as well. So how do I get an individual maybe to use safer, or to use less, or to employ some of those protective strategies? How do I make sure that they are surrounded by individuals who are also employing that, and make it as as positive that you can, but as safe of an environment in their use that they can? So if we're thinking, if we start with alcohol, how do I get one individual to alternate? In college, we talk a lot about alternating alcohol and water. So if I go out for a night, how can I get that individual to alternate a beer and a glass of water? But then that interpersonal, how can I make sure that that group of 10 has at least one sober person who can keep their head when the fight happens, or to make sure everybody gets home safe? How can I make sure that that community level is supporting that reduction in harm, and maybe has not 24/7 alcohol service, right? So we cut off alcohol service at some point, and then that big broader society and having that harm reduction. We are going to move into our actual harm reduction. I'm looking at it and defining it as a set of practical strategies and ideas that are aimed at reducing those negative consequences. And so this is one of the PTTC slides where it says drug use, but really this is any sort of substance, right? So we're trying to reduce those consequences associated with the substance use. But what I think is super important, always has been, but especially now, is this idea and this belief, and the fact that harm reduction is built off of a movement for social justice, for this belief and respect for the rights of the people who are using drugs, and again, using substances. They may not be doing or making decisions that I would support, but they're still people. They still have rights. And how can I get them to a point where they are supported, and when they're ready for those extra resources, that they've got them? Also important to recognize that it's all activities, everything we do in life has some sort of risk in it, right? So unless I am sitting at home by myself, not moving, I am engaging in some level of risk. A lot of times it's low level risk, but everything we do has risks. And so we're trying to essentially reduce the level of risk, or the amount of risk that we have. I do have a video that I want to show, at least the first minute or so. Here. So we're going to watch about the first minute.
Look, you're smart, you're cool, and you don't want to die, so you do things to reduce the harm of the risks you take. That's called harm reduction. It's all around us.
Taxi!
Harm reduction is common sense. It stops people from being injured and dying from things that are preventable. It saves lives, it saves money. It's smart. Here's a fact. Last year, 47,000 people died of drug overdoses in the United States. Because you're smart, you know these deaths are preventable. But here's something you may not know. Some kinds of prevention don't work.
Just say no. Who taught you how to do this? Any questions?
It's time to stop the drugs.
We've tried all these things, and still the number of people dying of overdoses continues to rise. But remember, you're smart. And because you're smart, you want to stop these preventable deaths. Do you know what is clinically proven to work? Harm reduction. You remember that, right? Harm reduction works for people who use drugs. It knows that people aren't perfect, but they deserve every opportunity to be as safe as possible. It encourages people to get educated and connected with healthcare. Harm reduction provides access to naloxone, the drug that reverses overdoses. It provides people with sterile supplies to prevent the spread of HIV and viral hepatitis.
Sorry about that. right, so far behind. So I apologize, but we do have another video as well that we're going to look at if I can get there on time. But it's just this idea that harm reduction, we think about it often as, safe syringe programs or naloxone distributions, and that's important. But harm reduction is also, as it had, sunscreen and seatbelts, and some of those really easy things that we don't push back on a lot of times anymore. But when we think about harm reduction, there's a lot of history as to why it gets stigmatized. But we're really focusing on those who are actively using a substance, whether that's alcohol or opioids, and how do we then support them and work through that. So harm reduction, one of the things I really like is that it is grounded in these 8 guiding principles, which even if you stay in the realm of, universal prevention, I think a lot of these are things that you should adopt if you don't already. So this non-judgmental approach, we've got to pull out some of the beliefs of substance use being a moral failing and have this non-judgmental approach. I mentioned earlier that to me, things that are evidence-based and feasible and cost-effective should be a no-brainer. Those are things that we should be doing. As well as making sure that we understand that behavior change takes time. I can't implement anything and expect a community of people to change their behavior in a year, most likely. It's multiple years. It takes those small baby steps. It often takes, a couple of steps back before we can take a couple of steps forward. And this, again, focusing on harm reduction, this meaningful participation of individuals who are using or are previous users, and the stakeholders in shaping how they are impacted by policies and practices. So this meaningful participation, when we think about harm reduction, we're looking at those with that lived experience. But when we're thinking about universal prevention, this is inclusion of the population of focus. So it's that cultural piece, that cultural humility or cultural competence piece. We also should be focusing on, and the guiding principle number 5 is to enhance that quality of life, not necessarily abstinence. For some people, higher quality of life comes with abstinence, but really it's that individuals need to decide for themselves what is the quality of life that they, highest quality of life that they can get, and how do they get there. We got to recognize that it's a complex set of social factors, and we've got to empower individuals to take control of their life and their decisions to reduce the harms to themselves. And again, this commitment to defending universal human rights. So these are all kind of the guiding principles coming from the Harm Reduction Coalition, as well as, just kind of well established. But I think especially if you change some of the phrasing of this, to get down to the meat of it, these are all things that we should be striving for in prevention anyway. And so that video had some strategies, but as we start to think about what are some of the strategies that exist for harm reduction, there is a plethora of them. This is just a few. So we can think about, like I said, that safe syringe program or sterile syringe program or exchange programs. But we just came out of a pandemic, so masks and vaccines, those are harm reduction as well. We might want to distribute naloxone and overdose reversal kits or overdose education kits, but also those fentanyl test strips for those individuals that are going to use, to at least be able to test their stash to know whether or not it has fentanyl in it. Fentanyl right now, at least in Johnson County, is a huge contributor to our increase in overdose deaths. Like I said, there are many other harm reduction strategies. So we could think, if we stayed more, at least stereotypically, in alcohol impaired driving, how do we increase or decrease the amount of impaired driving, either through designated driver programs or safe ride programs, those types of things, giving legal immunity to individuals who witness an overdose or alcohol poisoning, call 911 and help. How do we, give them that protection? Those types of things. All of that is harm reduction. It's reducing those consequences, right? Okay, I do not have time for this next video, so I will put it in the chat, and I'll send it out later because it's from NIDA, and it's a really good one. So if we think about prevention as focusing on those who are not misusing substances, and again, we defined prevention as preventing the use and misuse of drugs. As we get to that development of substance use disorder, we can think about prevention as trying to prevent that behavior from happening in the first place, but we can think of harm reduction as trying to prevent those consequences. So we might try to prevent youth from, or prevent individuals from starting to use opioids. But if they already are using, we at least want to keep them alive, right? We want to prevent the consequence of an accidental death by keeping them alive and keeping them around, ideally working towards that high quality of life for them, whatever that might look like, but preventing those consequences. And so when we think about how does prevention play into this, we can think about the things that prevention is really good at, right? So we're decently good, or should be good, at building community readiness. So let's build readiness for harm reduction. We are good, or should be good, at talking about substance misuse and substance use. So let's talk about stigma of substance use. I feel like we educate all things, right? So providing that education and resources, that connection, that community coordination, coordinating strategy implementation. And then how do we link all of this together to have an actual comprehensive approach to substance misuse in our community, whether that is in that role of universal prevention all the way up through treatment and recovery. I will send these slides out as a PDF because I'm going to jump through all of these pieces, because what I want to challenge you all to think about is how can you take maybe some of this that we've talked about. That's all. I'm going to go back through these a little bit. How can you take these back to your community and think about those of you most likely are in the prevention realm? How can you incorporate some of these items into what you're already doing to increase the harm reduction that's happening? So again, we talked about promoting community readiness to build support for harm reduction, correcting misperceptions, specifically thinking about stigma reduction and how do we increase that knowledge and awareness of substance use disorder opioid use disorder as it's an addiction, right? It's changed the brain's chemistry. It is something that is a medical condition. But how do we talk about it as a medical condition and promote use of non-stigmatizing language? Also thinking about, like I said, we're really good at doing some of this education and messaging and providing those resources and that community connection. So maybe that's some of the things that we can do is to create resources or, expand our prevention messaging to also talk about awareness and support for harm reduction. And this is, again, one of those where, we're really, as a field, I think prevention is really good at some of these things, but we have to make sure that we stay really good at this with support and guidance and development content from those with lived experience. So you cannot just, build this nice presentation and then go tell people, hey, there's all of these things, if you are missing that population and that individual and content from individuals who have lived it and who actually know what it's like and how we should better approach it. But as preventionists, we probably bring a lot to the table in terms of developing and delivering trainings that may or may not be the strengths of those that we're working with. So again, that leveraging of our traditional background in prevention and training in prevention, and how do we meld that with those areas that we are not experts, and vice versa. And again, this is one of my bigger soapboxes, at least the past couple of years, is how do we coordinate this strategy by thinking broader than just maybe what we've been thinking. So as Kimberly talked about, maybe not just focusing on preventing substances, but this challenge to expand it out. How do we change some of those or impact some of those social determinants of health? How do we recognize that individuals carry trauma with them, and how can we impact and improve some of those risk and protective factors that'll have so many downstream impacts, but doing so in a coordinated way so that we can, again, use our strengths but pull in the community and the broad coalition as a whole so that different sectors understand their individual roles in having some of these impacts. And this, I promise, this is a PTT slide, and we picked a really great name with calling ourselves Upstream Prevention, but how do we link some of those downstream consequences, that harm reduction that we're doing downstream, with those upstream prevention efforts? So again, focusing across the continuum, across different behavioral health silos that often exist, and then do something. So I'd love for you, I have just a couple of minutes, if you've got a question, to put it in the Q&A pod at this point, so I can bring it up. But I'd love to know what you might do with all of this. What are some things, if anything, that you can take from here to better incorporate harm reduction into the efforts that you're doing? Because again, those of you, at least the names that I recognize, you're all prevention people. So what can you do to incorporate this in? And hopefully it's not nothing. Thank you, Erica. So better networking in the community, pulling people together. There's not very many of you, so you've got to chat in things. I'm not going to wait. I'm not going to force it too much, but I do challenge you to think about what it is that, you know, what small piece or small different thing you could do to incorporate this a little bit more, whether it's, as Erica has, networking or community education, as Michelle put in there. What is that extra, you know, couple of steps that you can do to expand what you're already doing, to be both more inclusive and broadening things out, so that we, you know, have as Michelle would say, a longer table and, you know, a bigger umbrella to fit everything in. And yes, Kimberly, being a champion for those strength and protective factors, positive childhood experiences, being inclusive and equitable, all of those things, great. If you have questions, feel free to put them in there. If not, you've got a nice dinosaur QR code that will take you to the short, and I promise it is short evaluation for this. Like I mentioned, this is, and it's also now in the chat box, this is a training that was funded by or falls under one of our grants. And because we have a grant, we need to worry about and gather some of that data on our strategies and on this webinar specifically. So if you wouldn't mind completing that, I think it's like 6 questions, 7 questions, shouldn't take you too long. I'd greatly appreciate it. I will email it out along with a copy of the slides as a PDF. And then we do take our webinars and get them up onto YouTube and embed them into our website. So you can see our website there. That second QR code will take you to our homepage. But if there are no other questions, I'm going to go ahead and stop the recording. And then I will hang out for the last minute or a couple more minutes to answer any questions that you all might have. Thanks for being here so much.